lecture is about diarrhea in children. Definition of diarrhea is defined as passage of three or more liquid or watery stools within 24 hours. Diarrhea may have any of the following characteristics, which includes increase in frequency of the stools, increase in fluidity of stools, increase in weight of the stools. The change in consistency of the stool is more important than the change in frequency. What is not called diarrhea is frequent passage of formed stools that usually happens in irritable bowel syndrome, and passage of pasty stools in a breastfed infant, passage of watery stools by a newborn after 3 to 4 days of birth, and passage of stools during or immediately after feeding a newborn due to initiation of gastroparesis. This is called transitional stool that occurs in newborn after 3 to 4 days because of the change in the breast milk from early breast milk to transition milk. Then what we need to ask in history for a patient with diarrhea is the age. Age indicates probably indicates the cause of diarrhea. In 6 months to 2 years, the cause is most probably cow milk gluten allergy, or it can be lactose intolerance. From 2 to 5 years, can be celiac disease. More than 5 years, it can be irritable bowel disease. And older children, the cause can be irritable bowel syndrome, diarrheasis, Coats abdomen, gastroenteritis, and in all the other ages, it can be gastroenteritis because of antibiotics induced diarrhea, like ampicillin can cause diarrhea in children, food poisoning, and sepsis. Next, we need to ask about the onset of diarrhea, whether it is acute or insidious, duration, frequency, how many stools they are passing per day, and stools. About the stools, we need to ask about the consistency, whether it is watery or whether it is rice water like or semi-solid. Color, it can be mixed with blood, or the color can be rice watery white in case of cholera. Volume, whether it is small or large. That is useful in case of small bowel or large to differentiate between small bowel and large bowel diarrhea. Foul smelling or not. Character, if it is frothy, oily, or sticking to pan, it can indicate something like cystic fibrosis in the child. Associated with blood or mucus, use of any laxatives because the child has had constipation and the parents might have used laxatives. Whether associated with any drug intake, presence of any worms and stools. Usually, worms and stools can also lead to diarrhea. And even after giving albendazole to the child for deworming, that can also sometimes cause diarrhea. And the precipitative and relieving factor, whether any particular type of food is causing inducing diarrhea, like spices or anything, that is precipitating this issue. The coexisting symptoms that we need to ask is whether there is any vomiting that is usually able to differentiate between gastroenteritis, or whether it is whether the upper GI is normal and the problem is only in the lower GI, and whether there is any abdominal pain or bowel rolling movements. That usually doesn't happen in diarrhea, it happens in dysentery, like Shigella dysentery or ETC has abdominal pain that is quite severe, or IBD and pancreatitis. And the association with fever usually indicates an infection. Tenesmus, feeling of difficulty during defecation, whether there is pain during defecation or not. Abdominal distension, sound as the gas moves through the intestine. That usually happens in diarrhea. Altered sensorium or conversion. And whether there is any fever, features of dehydration, like things of thirst, drowsiness, prolonged skin pinch, bladder history about the urine output. Uh, Urine output, this is also another feature that indicates whether the child is dehydrated or not. And burning during urination, UTI. In younger children, UTI can present as vomiting associated with or without stools. Oral intake. Does the child take feeds during the illness, or if the child is not able to take feeds because the has severe dehydration, and the amount and the type of fluid taken by the child that also needs to be taken. The stool features help to differentiate what type of diarrhea it is. If it is due to lactose intolerance, the stools are usually noisy with borborygmi, and the stools are consist of soupy consistency with sour taste and sour bottom. Sour taste in the sense acidic pH. While measuring the pH of the stools, it will be low, and the child has sour bottom with acidic stools. Fat malabsorption. This child has frequent brody foul-smelling stools that floats in water because of the fat contents, and it fixes to the fat so that flushing will be difficult. This seen in case of cystic fibrosis and conditions, or in conditions where there is fat malabsorption in children, and inflammatory bowel disease. The child has recurrent blood and mucus in stools. IBD, the child has either constipation or loose stools alternating with each other. So the child may have pellet or ribbon-like stools. Starvation diarrhea, the child has small greenish and there is no fecal matter. Dysentery, it's usually blood stained, and cholera is rice water stools. Inquire about whether the child has any food allergy or intolerance to certain foods by asking about the following. Diarrhea following intake of cow's milk, that is cow's milk protein allergy, whether if it's present, or it usually happens during weaning after 6 to 8 months of age. Child usually presents with continuous episodes of loose stools. That is when they introduce cow's milk in the child's diet. And diarrhea following the intake of wheat, that is celiac disease. This also occurs during weaning a little later after 8 to 12 months. And diarrhea following intake of milk. It is usually present a little after birth, some 1 to 2 weeks after birth, where the child has loose stools, but it's lactose intolerance. Diarrhea following the intake of diet containing sugars can be seen in sucrase or isomaltase deficiency. Effect of withholding food in osmotic diarrhea. If food is withheld, the frequency of the stool decreases in that. Examination of the abdomen. We should take this detailed history along with this, like usually the past history, whether the child previously also had any episodes of loose stools, or if the child has any episodes of other illnesses associated with diarrhea, like frequent episodes of URI, LRI, or if the child recently had any measles or any other viral infection. And also, we should take into history the family history, whether there is any history of family history of lactose intolerance or family history of cystic fibrosis like illness. So all those things we should take into account. Whether what was the treatment that was taken previously, and going into examination, inspection of the abdomen, abdominal distension. whether there is any uniform or localized swelling that is present in the abdomen. Usually it should not be there in the case of normal diarrhea. Flanks are either free or full. All quadrants move well with respiration. Veins of the abdominal wall visible, dilated, whether they are tortuous, and the position of the veins, whether there are anterior, lateral, or back, and the direction of flow in the veins. This indicates whether the obstruction is in superior vena cava or in the inferior vena cava. Then visible gastric pulsations and visible intestinal pulsations. Skin, whether it is stretched or shining in cycles. Scars or whether any signs are present. And look for any plastics. Ascitic tapping, whether it is being done. And hernial orifices and external genital. For completion. Palpation of the abdomen, whether it is soft or tense, or whether there is any localized tenderness, padding or rigidity, or going for a surgical cause of acute abdomen. Palpable masses, whether there is anything present. Then auscultation. Normal frequency of bowel sounds is about 3 to 5 sounds per minute, and it should be checked whether there is any increase or decrease in the frequency of bowel sounds. So, going to the definition of acute diarrhea. Any diarrhea that is lasting for less than 14 days. And acute self-limiting diarrhea is from 3 to 4 days, 3 to 7 days, and it is usually infective. Acute, prolonged, or intermediate diarrhea usually lasts for 8 to 14 days. Chronic diarrhea, in this, the loose stools are usually non-infective and they present for more than 2 weeks. Usually, the causes are inflammatory, or there can be any bowel pathology like IBD, or inflammatory bowel disease, or infectious bowel disease, or irritable bowel disease, immunodeficiency, malabsorption, simple persistent diarrhea for more than 14 days. It usually begins as an infective origin. Persistent protracted diarrhea with malnutrition for 14 days. That usually lasts for 14 days. That is present with malnutrition. Persistent diarrhea is defined as acute onset of diarrhea that is of infectious origin or post-infectious sequelae like disaccharide intolerance, which lasts for 14 days or more. It can be of 2 types, simple persistent and persistent protracted diarrhea. Simple persistent is the one that responds to dietary modification, and persistent protracted diarrhea is associated with more severity like weight loss, and it does not respond to diet modification. So this diarrhea that usually begins as an acute onset diarrhea, but it lasts for more than 14 days. The following factors predispose a child with acute diarrhea to develop persistent diarrhea, that is malnutrition, immunocompromised child, extra gut infections such as pneumonia, UTI, septicemia, HIV, parasitic infestations of the gut, improper treatment of acute diarrhea. These can lead the child from acute diarrhea to develop persistent diarrhea. And going to the definition of chronic diarrhea, diarrhea that is due to a non-infective cause that is lasting for more than 2 weeks duration, that is called chronic diarrhea. It should not be an acute cause, it should not be an infective cause, and the duration should be for more than 2 weeks. It can occur in a previously normal child or a child with other inherited defects. So some of the common causes of chronic diarrhea according to age group in newborn 1 to 2 years and above 2 years. In newborn, the common causes are congenital short bowel syndrome, neonatal lymphangiectasia, inherited transport defect like cystic fibrosis, glucose galactose malabsorption, congenital chloridoria, bile salt malabsorption, milk enterocolitis, exogenous pancreatic deficiency, primary or secondary lymphangiectasia, hypo or A beta lactoproteinuria. These are the common causes in newborn and in 1 month to 2 years of age. The common causes are lactose intolerance, cow's milk, soy milk, or other milk allergies, celiac diseases, irritable colon of infancy, chronic non-specific diarrhea, cystic fibrosis, Clostridium difficile associated antibiotic associated diarrhea, whether to metronidazole or something. VIP is breaking periods. And then about 2 years of age, uh, celiac disease, inflammatory bowel diseases, chronic non-specific diarrhea like irritable bowel syndrome, primary acquired lactase deficiency, tropical fruit, chronic pancreatitis, exocrine pancreatic deficiency, primary or secondary lymphangiectasia, hypo or A beta lipoproteinemia. Protracted diarrhea. It refers to chronic or persistent diarrhea in a child that these are the causes earlier also that results in malnutrition or failure to thrive. So before labeling a child as having protracted diarrhea, the following must be present. 4 or more liquid stools per day, and the duration of those stools should be for more than 14 days, and the child should be sick, significant weight loss, or there is a failure to gain weight. Diarrhea that is refractory to conventional line of treatment. So all these 4 should be there to label a child to be having protracted diarrhea or refractory diarrhea. So to differentiate, to find the main causes between small bowel diarrhea and large bowel diarrhea. The common viruses that cause small bowel diarrhea are rotavirus, Marburg virus, astrovirus, calcivirus, rotavirus, and the common bacteria causing small bowel diarrhea are Vibrio cholerae or ETC. And parasites are Giardia lamblia, Strongyl earth species, or Cryptosporidium. So the most common virus that we need to remember is rotavirus. Large bowel diarrhea. Here, mostly it is due to bacteria or parasite like Shigella, EIEC, EHEC, Salmonella, Campylobacter jejuni, or certain parasites like Entamoeba sciatica, Trichuris trichura, Ballantidium coli, or Cysticercosis. Differentiate between small intestine diarrhea and large intestinal diarrhea. The according to the thesis, whether the stool volume, usually in small intestine diarrhea, the stool volume will be large, but whereas in large intestinal diarrhea, it's usually associated with small volume of stool because most of the fluid is being observed in the small intestine itself. So when it comes to a pathology in large intestine, the loose stools are usually of small quantity. And mucus and fresh blood is common in cases of large intestine diarrhea. And the blood is actually altered in case of small intestine disease because of the hemoglobin being acted upon by enzymes in small intestine, and there is only melena here, and there is no fresh blood. And usually fat, which is being absorbed mainly in the small intestine, and only if the pathology is in small intestine, it is sometimes present in stools, and it is fat is absent in case of large intestinal diarrhea. Color of the loose stools is mostly variable, whether it can be because of pathology. The small intestine, it can be yellowish or it can even be greenish in case of certain parasitic areas. or it can be rice watery because of cold. Undigested food that is occasionally present in case of small intestine, and undigested food usually doesn't reach the large intestine, so it is absent here. Tenesmus is common in case of large intestinal area, and the frequency of the stools is about around 2 to 3 times in case of small intestinal diarrhea and around more than 3 times in case of large intestinal diarrhea. And urgency to pass the stool usually comes because of the receptors in the large intestine. So the pathology in large intestinal diarrhea causes urgency to pass stools. Other signs such as vomiting is sometimes seen in small intestinal diarrhea, and gas is also sometimes present in case of small intestinal diarrhea. Whereas weight loss is common in small intestinal diarrhea because of the fluid that has to be absorbed by the small intestine, not absorbed. This is now after differentiating and examining the child, we need to assess at present the child, the clinical state of the child. So we need to assess the dehydration and nutritional status. Sepsis screening should be done. And the feeding habits of the child has to be noted. It has to be noted in case of any malabsorption is there, and any associated symptoms such as fever, and analyze the type of diarrhea, whether it is acute or chronic, passage of any blood or malnutrition. Then we go on to the plan of dehydration. So classifying diarrhea, we go from no diarrhea to some diarrhea to severe diarrhea. So no diarrhea doesn't have the clinical signs. Classify it as some or severe diarrhea. So it doesn't have any other clinical signs. So usually it is treated with plan A. So some dehydration has some or more of the following signs. Restlessness, the child is irritable, child has sunken eyes, and it drinks eagerly or thirstily. Skin pinch goes back normally. So if any two of the following is present, then it is classified as some dehydration. So the plan is plan B, severe dehydration. Any two of the following signs are present, like lethargy or unconsciousness, sunken eyes, not able to drink or drinking poorly, skin pinch goes back very slowly. So this goes under plan C. So what are the signs of dehydration that we see for a child from head to toe is, if it's a newborn, less than around 1.5 years of age, we can see the anterior corner, whether it is sunken or depressed, or whether if it is a little below the surface. So that gives you a little assessment of the dehydration status of the child and the overall status to see that whether the child is normal, or whether the child is restless or irritable, or whether the child is unconscious or lethargic, showing apathic behavior. So that differentiates between no, some, or severe dehydration. And then going to the eyes, you can see whether the eyes are sunken or not. And then going to the mouth, you can see the tongue, whether the tongue is dry or the tongue has some saliva. Then going to the abdomen, you can check for the skin pinch. Usually the skin pinch goes back little slowly, but normally it should not be delayed for more than 2 seconds. And if it is more than 2 seconds, you can classify it as skin pinch goes back slowly, and more than 5 seconds as severe dehydration goes back very slowly. Then you can see capillary refill type. Normally it is by blanching the child, usually it is done in the child's soul. We'll have to blanch and leave it, and to see the capillary refill that is happening back. Usually it is less than 3 seconds, and if it is more than 3 seconds, then the child has some dehydration. We'll have to also assess the pulse of the child. to see whether the child is in shock or not. So this picture shows the child with signs of dehydration. The skin looks dehydrated and dry. The abdominal skin pressure, even when seen, it has not gone back. So the child has features of dehydration, and drinks eagerly comes at some dehydration. We used to see capillary filtration, usually done in the soul. So according to IMNCI, what are the things that we need to ask? The loose stools, for how long to assess the duration, whether if there is any blood in stools to differentiate between diarrhea and dysentery. In feel, for the child's general conditions, the child in lethargy, unconsciousness, or able to differentiate between some severe dehydration. Look for sunken eyes, offer the child fluid, and is the child not able to drink or drinking poorly, that comes under severe dehydration. Drinking eagerly or if the child is thirsty comes under some dehydration. And pinch the skin of the abdomen, does it go back? If it is very slowly, longer than 2 seconds, severe dehydration, or just slowly, then it is some dehydration. So this is the same. And if the diarrhea is present for more than 14 days, and we'll have to see whether the dehydration is present or there is no dehydration. If there is dehydration, it is severe persistent diarrhea. And if the diarrhea is present for more than 14 days and there is no dehydration, it is persistent diarrhea. So for severe persistent diarrhea, we'll have to treat it as according to the severe classification. And for persistent diarrhea, you will have to just give the child multivitamins and like zinc to follow up the same. According to the presence of blood in stools, we'll have to treat the child with oral antibiotics. According to Shigella treatment, we usually give cefixime at 8 to 10 mg per kg per day in 2 divided doses for around 5 to 7 days, and treat dehydration and give zinc. Follow up the child, that is free. So according to plan A, for no dehydration, ORS is given, and ORS packet, we usually advise the mother to mix one whole packet in 1 liter of water. Because over mixing or under mixing does not give the required proportion of the ORS that is needed, and under mixing of the solution, 1 packet of ORS in 100 ml of water is more toxic and poisonous. So that needs to be clearly explained to the mother. If the child is of less than 2 years, 50 to 100 ml per day has to be given. Per loose stools has to be given. And if the child is of 2 to 10 years, 100 to 200 ml per loose stools, usually 1 liter per day is the maximum. And 10 years or above, the child can drink as much as they want. At least the child should drink up to 2 liters. And along with the ORS, the child is advised syrup zinc because zinc is believed to remodel the intestinal epithelial cells. So for less than 6 months of age, it is 10 grams per day, and more than 6 months of age, it is 20 grams per day, and it is given for 2 weeks. The syrup Zincovit that is available usually contains 20 milligrams per 5. Warning signs: mother is instructed to return to the healthcare center in the following condition. When there is a high purge rate, when there is severe or persistent or frequent vomiting, there is marked thirst, refusal to drink or eat, blood in stool, fever, child not getting better within 3 days, fever, rice watery stools, which is cholera, anuria or failure to pass urine for more than 12 hours, and if there is any altered sensorium, drowsiness, or convulsions. So, according to Plan B, ORS or lactate is given according to whether the child is able to drink the fluid properly and according to the age of the child. The child is able to drink the fluid orally. The dosage is usually ORS is given 75 ml per kg as the child tolerates at least between 4 to 6 hours. And if the child is not drinking properly, if the child also has associated vomiting, then it is better given to repeat lactate is given of the same dosage, of the same volume, 75 to 100 ml per kg, that is given over 4 to 6 hours. So, plan for Plan C, severe dehydration. The totally 100 ml per kg of fluid should be given to the child. So, in infants less than 12 months and infants more and in children more than 12 months is divided into two. So, the target 100 ml of fluid is divided as 30 ml that is given in the initial phase and 70 ml per kg body weight that is given in the next phase. So, the initial 30 ml per kg in infants in less than 1 year of age, it's given for 1 hour, and in children more than 1 year, it is given usually at half an hour time, and the rest 70 ml per kg of fluid is given in around 5 hours of time in infants less than 12 months, and in older children it is given in around 2.5 hours. So the total duration of the whole 100 ml per kg fluid is given in infants less than 12 months in around 6 hours, and in children more than 1 year in about 3 hours. So after the first treatment that happens during the initial 30 ml per kg, the child has to be assessed. And whenever the child is able to drink orally, the child can be given some ORS in between the treatment also. And after 6 to 3 hours, we have to reevaluate the child. Now, whether the child is in Plan A or Plan B or Plan C, usually the child should go to Plan A. So, what is the composition of the ORS that is available? Initially, the standard ORS has had an osmolality of about 311 milliosmoles per liter. Now, the new WHO reduced osmolarity of the ORS is around 245, which contains 75 glucose, 75 sodium, 65 chloride, 20 potassium, and 10 citrate. Resomol is the fluid that is given to children with dehydration with malnutrition. So the osmolarity of resomol is a little lower, which is 240, and it contains more of glucose and less of sodium and other solutes. So this is the ORS pack that will be available mostly. So the composition that is present in each sachet is sodium chloride about 2.6 grams, potassium chloride of 1.5 grams, sodium citrate of 2.9 grams, dextrose, sugar that is present in 13.5 grams. So the total volume of the solution is 21.8 grams. So the disadvantages of conventional WHO ORS, that is high osmolar contain high osmolarity, is poor acceptability due to the high sodium and chloride content. The taste is more salty. Increases the volume, pulse rate, and duration of diarrhea. Because of the high sodium content, about 90 milliosmoles, 90 is present in WHO, and then the new reduced osmolarity is about 75. This provides too much sodium, which is dangerous to an edematous child because the sodium that we give orally or IV goes through the bloodstream, and The edema from the interstitium space will try to enter the bloodstream, which contains which is now contains high osmolar solution. So, because of the massive fluid shift, the child will go into congestive cardiac failure. And because of the potential risk of hypernatremia, it may not even be an optimal solution to correct the dehydration status in a severely malnourished child. So, advantages of low osmolality ORS over conventional ORSs: treatment of acute diarrheal disease in newborn and young infants. Reduced osmolality ORS is as effective as standard ORS in adults with cholera. Reduced osmolality ORS promotes more effective water and sodium absorption than the WHO ORS. There is less stool output and decreased frequency of vomiting and no additional risk for developing hypernatremia because it contains less sodium. More stability of reconstituted solutions. Decreases the number of hospitalizations because it can be given by the health worker. Advantages of the reduced osmolality ORS formulation for general use, including malnutrition, is that a single formulation would be promoted for all ages, irrespective of the etiology or the nutritional status of the child. So, if ORS is not available, then cereal-based ORS or rice-based ORS, that can be considered super ORS, can be given. The rice-based ORS is clearly superior to the WHO ORS in efficacy in patients with cholera. The two solutions are similar in efficacy in non-choleric. So the advantages are decreased purge rate and slow release of glucose from starch. And ORS with micronutrients that helps in absorption of water and sodium. Zinc fortified ORS, the advantages of it modifies the course of diarrheal illness, decreases the severity of diarrhea, prevents recurrent episodes of diarrhea. So, what other fluids can be given? Home-based fluids in cases of children with diarrhea where ORS is available. Lemon water, usually 1 liter of water with 4 spoons of sugar and 1 spoon of salt, has similar composition to WHO ORS. Rice water, soups, dal water, lassi, coconut water or any plain water. Not recommended solutions are simple sugar solution, liquid solution, carbonated soft drinks, fruit juices, fluids for athletes and other drinks, gelatin desserts or pickles. So, going to the lactose intolerance. Children with lactose intolerance, for them, the treatment would be to limit or stop the providing any type of lactose sugar in the diet, to stop milk. We can try to give soy milk or any other milk components to see if that causes diarrhea or not. If that's also causes diarrhea, then all milk and milk components and soy milk has to be stopped for a child. In case of fat malabsorption, the reason for malabsorption, the cause has to be found for the child, whether it is due to cystic fibrosis or any other fatty acid disorders are there, and that has to be treated. And for the time being, limitation of fat content of the food is done. IBS is usually a diagnosis of exclusion. So after excluding all the other causes, we can do IBS. Dysentery, Shigella dysentery or ETEC. For that, cephalosporin or fluoroquinolone type of antibiotics can be given 5 to 7 days. Cholera, rice water stools, Staphylococcus doxycycline.